Hi friends, I would like to welcome you all for today's lesson, which is on respiratory system, specifically on the mechanism of breathing. Pay attention to link up this lesson on the previous lessons that we have had when we're looking at the lower respiratory system and also the upper respiratory system. So we want to see how the mechanism of breathing actually takes place as you are actually carrying out the respiratory function or mechanism. So we're saying that the mechanism of breathing in this case, we are much concerned with the movement of air, which is inside and outside the alveoli. Because the alveoli, just like we mentioned earlier, this is the functional unity of the lung where the gaseous exchange actually takes place, where the gases from the external atmosphere gets to be extended with those that are in the bloodstream, or rather this is when oxygen that is within the lungs gets to be diffused into the blood for it to be circulated to all parts of the body, and where the oxygen actually gets to be excreted or expelled outside the body through these alveoli. So that's what actually we are concerned much with when we say ventilation, the movement of air into the alveoli and outside the alveoli. And this mechanism actually takes place through the process of inhalation and exhalation. When we say inhalation, in this case, we are just talking about the taking of air inside the lungs. And the exhalation, this is a taking out of air from the respiratory tract to outside the environment, which is in the atmosphere. And this actually, it is enhanced by the nervous system and also the respiratory muscles that we are going to talk about in today's lesson. So first thing that you need to understand is that this respiratory system, it is actually regulated by the respiratory center that is located in the medulla oblongata and the pons of the brain. So the impulses are going to be generated from these respiratory muscles or the respiratory centers to the respiratory muscles that are going to yield the mechanism of breathing, which is the relaxation and contraction of the muscles of the thoracic cavity, so as to ensure the lung expansion, and it enhances the mechanism of breathing. So we're saying that the muscles that are actually responsible, or those that receives the information or the impulse from the brain, which the respiratory center is located, the muscles includes the diaphragm, also the external intercostal muscles and the internal intercostal muscles. We are going to talk about each of these muscles and to see how actually they work in the mechanism of breathing. So we're saying that the diaphragm in this case, what you need to know about this muscle, it is just a muscle which is a dome shaped, and it is found below the lungs. This is the muscle that actually divides the thoracic cavity from the abdominal cavity, and it actually acts as a it's more like it shapes the cavity of the abdomen where the organs are found, and also the organs that are found within the thoracic cavity rest on this dome-shaped muscle, which is called the diaphragm. So when this diaphragm gets to contract, it means that it is going to flatten, or it is going to appear straight, and it moves downwards in order to increase the area that is above in the thoracic cavity, and this means that actually the person is taking in air. We're going to talk about its mechanism, worry not. And we're also going to talk about the intercostal muscles that are found between the ribs, where we've got both the external intercostal muscles and the internal intercostal muscles. So these internal intercostal muscles, they pull the ribs upwards and the outwards. And we're going to talk about what does this mean. When this happens, what actually does it mean? Is it the time when the person is breathing in, or the time when the person is breathing out? And also we're going to talk about the internal intercostal muscles that actually pulls the ribs downwards and inwards. We move on. So here we've got the visual aid that is showing how the diaphragm appears. So we have said that the diaphragm actually it is a dome-shaped muscle. So as we can see in this case, this is what we mean when we say dome-shaped muscle. And when it contracts, we are saying that it is going to appear straight. We are going to demonstrate how it appears in this case. So this diaphragm fits into the thoracic cavity, like the second diagram that we can see here. We see that the diaphragm actually fits in the thoracic cavity, making the division of the abdominal cavity and that of thoracic cavity. So that's what we mean when we say the diaphragm. And remember what we said about the diaphragm. We said that when the diaphragm contracts, it is going to actually get to be flattened and moves downwards so as to increase the surface area of the lung expansion. So now all these muscles that I've said, how do they work in order to regulate the breathing mechanism? First thing, let's talk about respiration at large. So we're saying that inflation and deflation of the lungs occurring with each breath ensures that regular exchange of gases takes place between the alveoli and the external air. When we say inflation in this case, it is the accommodation of air that actually increases the lung capacity. And deflation is the expulsion of air from the lungs, which actually decreases its capacity inside. So we're saying that this mechanism of inflation and deflation ensures that actually gaseous exchange takes place within the alveoli. And the muscles of respiration, just like we have already introduced them, they actually works in the expansion of the chest during inspiration, occurs as a result of muscular activity, partly voluntary and also involuntary. So what we mean in this case, we talked about those muscles that actually works in the respiratory mechanism. So they are said to be partly voluntary, in a sense that mostly when actually the person is doing the forced breathing, the forced inspiration, or the forcive expiration, you find that it will be considered as the voluntary. You are regulating how much to take air. And it can also be said to be voluntary in a sense that you can able to hold the breath. You take in much air, then you hold the breath for a while. That is the regulation that we are talking about, being voluntary. And also at the same time, these muscles, they are also involuntary. In what sense? You don't regulate your breathing mechanism. Even when you are subconscious, you are not aware of what is happening. Actually, these muscles continues to contract and relax in order to enhance the respiration, or rather the exchange of the gases. So the main muscles of respiration in normal quiet breathing are the intercostal muscles and the diaphragm. Intercostal muscles, in this case, we mean both external and internal, and also the diaphragm. So we are saying that during difficult or deep breathing, they are assisted by the muscles of the neck, shoulders, and the abdomen. Can tell you to observe this. You can demonstrate if at all you want to do deep breathing. Take much air more than what you require during the breathing mechanism. You see that actually even the muscles of the neck, they are going to be involved. Even those, the muscles of the abdomen, they are going to be involved in this breathing mechanism. But under normal circumstances, are only the intercostal muscles and the diaphragm that are the primary muscles of the respiration. So we are saying that in terms of the muscles, we've got the first rib of the thoracic cavity, which is said to be fixed. This rib does not move. It is just adjacent to the clavicle bone, which is the collarbone. And by so doing, having that it doesn't move, and the muscles, they are connected to this rib. When the muscles contract, they actually pull the ribs that are downwards upwards. And this is the demonstration that we are seeing on this visual aid down here. So we are seeing that actually as the muscles contracts, the ribs are going to be pulled upwards and also outward according to their arrangement or the way they are shaped. So as they are pulled upwards, they are going also to go outwards. And as they are going to be released, when the muscles relaxes, these ribs are going to get back to downwards and also inward with an aid of the internal intercostal muscles. But the external intercostal muscles is going to make the ribs moving upwards and also upwards and outwards. So this is what we are saying. So here to the left we can see the arrangement of the internal and external intercostal muscles. So we see that actually these internal intercostal muscles, they're just inside or crossing the external intercostal muscles at the right angled, and then they are found between the ribs. And the diaphragm, we've already demonstrated or shown the visual aid that was showing the diaphragm. So we can see this is the first rib that we are talking about, just adjacent to the clavicle bone there. We've got the first rib that is actually immovable or fixed, where it helps the ribs to be moved upwards and outwards during the inspiration. So now the cycles of respiration, there are actually three. There's inspiration, expiration, and pause. All what we have been talking about are going to be highlighted in this part. We've been talking about inspiration and expiration, but we never talked much on them. But in order for us to have the solid understanding on this one, we are going to focus much of our attention on these three phases of respiration. And due to the research, main references differ. But our reference in this case, they are saying that actually the full cycle of respiration takes about 12 to 15 times in a minute. And when you say respiration, we mean taking in and out the air. That will be one, will be counted as one beat. Also, you take in and out, that will be 2. In and out, 3. So we're saying that those beats in a minute, or breaths that you are going to take in and out, they are going to count to about 12 to 15 minutes times in a minute. Other references, you find that they indicate up to 21, it will still be considered normal. 15 to 21 breaths per minute, it will still be considered as normal due to the reference that you can be using. So now let's start with the inspiration as one of the phase of the respiration cycle. So inspiration in this case, it is just the taking in of air, taking in of oxygen, so to speak, because in this case we are much concerned with the oxygen as our main or primary gas that we inhale. So we are saying that when the capacity of thoracic cavity is increased by simultaneous contraction by the intercostal muscles, the diaphragm, the parietal pleural moves with the walls of the thoracic and the diaphragm. So what we mean in this case, when the thoracic cavity is increased in contraction, it means that the diaphragm has contracted and flattened, also descends downwards. And then the external intercostal muscles, they are going to increase to contract, push the ribs upwards and outwards. Hence, what is going to happen? This reduces the pressure in the pleural cavity to a level considerably lower than atmospheric pressure. So, when this happens, the pressure that is within the thoracic cavity, it is going to be considered as lower than the atmospheric pressure. And when this happens, get in mind the concept of diffusion, how diffusion works. Particles will move from the from a higher concentration to the lower concentration. And in this case, we are saying that when that happens, the contraction of the muscles takes place, the concentration, rather the pressure, will be higher in the atmosphere rather than it is with the pressure that is within the thoracic cavity. So when this happens, the visceral pleural follows the parietal pleural, pulling the lung with it. So this means that when the lungs is pulled within the walls of the lungs are pulled, they are going to be pulled outwards, like in the outward motion, so as to increase the capacity of the cavity of the lung inside, that is to accommodate the air. After this happens, you find that this stretches the lungs, and the pressure within the alveoli and in the air passage falls, drawing air into the lungs in an attempt to equalize the atmospheric and the alveolar air pressure. So now, in order to stabilize the equilibrium between the atmosphere and that or the lungs, you find that the air will start moving from outside the environment into the lungs, so that at least the balance can be maintained, because we said that there will be the reduced pressure within the lungs, that unlike it is with the atmosphere. So in order to enhance or to ensure the balance, air will be moving from the air passages into the alveoli. And the process of inspiration is active as it requires expenditure of energy for muscles contraction. So this is just one type of the process that actually is said to be active transport, or which requires energy, because for the muscles to contract and relax in order to actually increases the capacity of the air to be accommodated, it has to be increased. Hence, the muscles requires energy to do that. And the negative pressure created in the thoracic cavity aids venous return to the heart and is known as the respiratory pump. So sometimes you may be asked, what is the respiratory pump? Actually, this respiratory pump is just the negative pressure that is created within the thoracic cavity in order to aid the movement of air, or rather movement of the venous blood to the heart. We are done with inspiration. So take note that inspiration actually involves the contraction of external muscles and the diaphragm. So when the diaphragm contracts, it moves downwards and flattened. Then the external muscles, when the external intercostal muscles, when they contract, they are going to pull the lungs upwards and outwards. What about in expiration, or rather expiration? In this case, we are showing that the intercostal muscles and the diaphragm results in downwards and inwards movement of the rib cage and the elastic recoil of the lungs. In this case, what will happen when you talk about intercostal muscles, we are primarily talking about the internal intercostal muscles now that are going to contract and pulling the ribs downwards and also inwards. And the diaphragm, it is going to relax, making that dome shaped and making the lungs reduce their capacity or their volume, the space that it has with air. And when that happens, it means that as it is being pressured, it is going to release the air that is contained within it, making expiration or exhalation, expiring of air or expelling of air from the lungs to outside the atmosphere. So as this occurs, we are saying that the pressure inside the lungs is going to exceed that of the atmosphere, and the lungs still contain some air. Okay, so as this happens, whereby the air exceeds that of the atmosphere, to ensure to maintain the balance, the air is going to be excreted or expelled to the outside environment to maintain the balance. So we are saying that the lungs still contain some air and are prevented from complete collapse by the intact pleural. We talked this when we were looking at the lower respiratory system. As expiration is taking place, it's not every air that is going to be exhaled. Remember, what we are trying to do is to maintain the balance between the atmospheric pressure and that of the lungs. Hence, to prevent the collapse of the lung, which we call atelectasis, we are going to have the balance, and the air, some amount of air is going to remain within the lungs. And we're going to talk about what is the amount of the air that is going to remain within the lungs after the normal expiration. And this process is said to be the passive process because it does not require expenditure of the energy, because we see external muscles are going to relax, the diaphragm is going to relax. So it's only the internal muscles that are actually going to make those ribs to get downwards and inwards, and so as to expel the air from the lungs. So we're saying that after expiration, there is a pause before the next cycle begins. Try to observe yourself as you are breathing in and out. You find that after you expire every air, there's a certain amount of time or seconds that you are going to pause before you take in another air, or take an observation on your friend without alarming them that you want to see what is happening. You see this happening. They will inhale, and expire or exhale. Before they take in another air, they'll pause for a few seconds. So this is what you are actually talking about. Those are the three phases: inspiration, expiration, and also the pause phase. Now let's talk about the physiological variables that affects respiration. What we were actually talking about in this case, we want to see the factors that actually influences the respiration or that affects the respiration. And as we are going to talk to get into the details about these factors, pay much attention to know how one factor actually affects respiration. The first one, it is the elasticity. When you're talking about elasticity, you are just talking about an ability of the lungs to return to the normal shape after each breath. For example, let's say you take in air and out, the lungs are going to remain contracted or constricted. They're going to reduce their capacity. And now, if at all there's any condition that is underlying that can prevent the lungs from expanding, that means that respiration is going to be altered or impaired or affected. So elasticity of the lung determines at what extent the respiration it is going to happen. Is it effective? Are the lungs able to contract and relax freely so as to enhance effective respiration or not? This is what we're talking about. So I'm saying that the loss of elasticity of the connective tissues in the lungs necessitates the forced expiration and the increased effort on inspiration because of other underlying conditions. For example, let's talk about the condition like in asthma. You find that the patient or rather an individual who is asthmatic will have the forcive inspiration because of the reduced elasticity of the lungs due to the underlying condition. Secondly, let's talk about compliance. Compliance is just one of the variable factor that affects respiration. In what sense? When we say compliance in this case, we are just talking about the distensibility of the lungs, or rather to what extent can the lung distend or increase in its capacity inside to accommodate the air. It is actually related to elasticity. That's why we're saying that when compliance is low, the effort needed to inflate the lungs is greater than normal, e.g. in some diseases that can actually prevent the lungs to increase. More especially when there's a scars on the lung, like that which is seen in pneumothorax, whereby there's accumulation of air within the lungs, and at the end of the day, the lungs is going to have pressure for them to distend or to increase in order to accommodate air. So this is going to affect the respiration. Thirdly, it is another factor, it is expired air. So we're saying that expired air, in this case, we are talking about the mixture of alveolar air and atmospheric air in the dead space. When you're talking about the dead space in this case, this is the respiratory tract only except the alveolar and the alveolar sac itself, but the whole respiratory tract, it is said to be the dead space, and it contains air. Just like we have said, after expiration, it's not every air that is going to be expelled from the respiratory tract. So we're saying that this mixture, it is going to affect the physiological function of the respiration mechanism, or it is going to alter this. If at all expired air is getting to be expired, every air is expelled from the alveolar, it means that the alveolar is going to collapse, and when this happens, respiration is not going to take place, hence it may affect. So the effective mechanism of expired air, it is going to actually promote effective respiration. Another factor, it is air within the atmosphere. How much air do we have in the atmosphere? Or rather, at the environment where you are, how much oxygen is it contained? Because this air, when you're talking about air, or a mixture of gases. Mostly we are concerned with nitrogen, oxygen, carbon dioxide, water vapor, and some quantities of other elements that are found within the air. And our main primary focus is on oxygen. So how much oxygen is it contained in the environment where you are? This is going to determine the respiration. When there's a reduced amount of oxygen, this is going to increase the respiration rate, whereby the person will start forcing the breathing mechanism so as to acquire amount of oxygen that is needed for him or her to promote the metabolic mechanisms within the body. So we're saying that each gas is in the mixture it exerts a part of the total pressure proportion to its concentration. Okay, so in this case we're just talking about the pressure that can be created outside and inside the alveoli in this case. And lastly, there is alveolar air itself. How much air does the alveolar remains with after a full expiration? This actually also determines the respiration, or it affects the respiration. So in this case we are saying that the composition of your air remains fair constant and is different from atmospheric air. So what we are saying, it is actually the balance that is going to be maintained between the atmosphere and also the alveolar. If this balance is not maintained, then the respiration it is going to be altered. After looking at those factors, we can talk about the diffusion of gases. How does this mechanism actually happens, the diffusion of gases? Okay, so we're saying that exchange of gases occurs when a difference in a partial pressure exists across the semi-permeable membranes. What are we talking about in this case is the pressure that we've already mentioned, that of the atmosphere and that of the lungs itself. And in this case, the pressure it is confined on the lungs and that of the blood. How much oxygen is contained in the blood compared to that in the alveolar, and how much carbon dioxide are contained within the blood compared to that in the alveolar sac. This is what is going actually to determine the diffusion of the gases, because we know that oxygen to move from the alveolar or from the lungs to the blood, it actually happens through the active transport. So we are saying that gases moves by diffusion from the higher concentration to the lower concentration until the equilibrium it is actually maintained or established. So what we are saying in this case, if at all there is a reduced amount of oxygen within the blood due to the fact that the systemic circulation has taken place and the cells have actually consumed the oxygen that was contained in the blood stream, as this blood is passing to the lungs from the right ventricle, the heart will be deoxygenated. Hence, oxygen is going to move from the alveoli, or rather from the lungs, to this blood. And carbon dioxide will be highly concentrated within the blood compared to that in the lungs, or rather in the alveolar sacs. So you find that the carbon dioxide will exit the blood into the alveolar sac through diffusion. And there's also like nitrogen. The amount of nitrogen that is exhaled, that is inhaled is exactly to the same that is expelled. Why is it like that? Because there's no primary function that this nitrogen is going to be used within the body. So in terms of the percentage, you say that 78% of nitrogen is going to be inhaled, and also the very 78 to be expelled. Let's talk about the lung volume and the capacity. Remember, I mentioned this in the introduction that we are going to talk about how much air does the lung need to accommodate at a specific point in time. So we are saying that in a normal coil respiration, there are about 15 complete respiratory cycle per minute, just like we have mentioned, 12 to 15 complete cycle of respiration in a minute. And we are saying that the different intensities in breathing move different volumes of air in and out of the lungs. What we mean, to what extent are you taking air? And to what extent are you expiring air from the lungs? This is actually going to determine the amount of air going to be accommodated within the lungs. And the lungs and the air passage are never empty, just like we have mentioned, so as to prevent the collapse of the lungs. And as the exchange of gases takes place only across the walls of the alveolar ducts and the alveoli, the remaining capacity of the respiratory passage is called the anatomical dead space. I guess I've talked about this already. So the whole respiratory tract, only apart from the alveolar ducts and the alveoli itself, are excluded on this anatomical dead space. And this you need to know what is an anatomical dead space. And the amount of air that is contained within this anatomical dead space amounts to about 150 mils. And we continue looking at the volumes, the lung volumes that now we are concerned much on. So we are saying that the first volume that you need to know, it is the tidal volume. So when you hear the term tidal volume, in this case, we're just talking about the volume of air that is inspired or expired with each normal breath. So when you breathe in and out, that amount of air that the lungs can accommodate during the normal breath is going to be called as the tidal volume. And this amount of air, it amounts to about 500 milliliters in the adult male. So this is just the statistics, so to speak, or the average. You find that in the normal adult, it's about 500 mils of air. Then we've got the inspiratory reserve volume. This is an extra volume of air that can be inspired over and above the normal tidal volume. So remember, we said that tidal volume is the air that can be accommodated within the lungs just during the normal breathing. So you find that as you are breathing in and out just normally, there's still some air that can be accommodated by the lungs. You can still force yourself to take in as much air as you can. So that amount of air that you can take in on top of the inspired air that has been inhaled under normal circumstance, it is what we call inspiratory reserve volume. And this air, it amounts to about 3,000 milliliters. And it shows that actually this air that we don't inhale under normal circumstance, it is more than that which we inhale under normal breathing. So you can even observe yourself again. Keep breathing in and out just under normal circumstance, and then you try to take much air. After a normal breath, take more air than you have already taken. You find that the lungs can still accommodate some air. Then we've got the expiratory reserve volume. This is the maximum extra volume of air that can be expelled or expired by forcible expiration after the end of normal tidal expiration. So as you are breathing in and out, you find that after you breathe out, you can still force yourself to breathe more air than that has been breathed out. So that air actually makes the volume that we call the expiratory reserve volume, and it amounts to about 1,100 millimeters, 1,100 milliliters. We also have the residue volume. The residue volume in this case is the air that is going to remain within the lungs after the forcible expiration. You force yourself to expire more air, but still there's air that is going to remain in order to ensure the lungs not to collapse. And what do we call that air? Or rather, how much does it amount to? It's about 1,200 mils or milliliters, and this is what we call the residue volume. So these are the essential volumes that you need to know when it comes to the lung volume. Let's talk about the lung capacity. The lung capacity, this is just the space that is going to be created within the lungs that is essential to accommodate those volumes we've been talking about. The first capacity is the inspiratory capacity. What does this mean? The inspiratory capacity, it is the capacity which can accommodate the tidal volume plus the inspiratory reserve volume. So the tidal volume is the normal that you can breathe in, and there's that one which you can force yourself to take in as well. So the whole amount of it, when you add that tidal volume under inspiratory reserve volume, it is going to make what we call inspiratory capacity, and it amounts to about 3,500, because we said that the tidal volume is 500 and inspiratory reserve volume 3,000. So when you add them together, it is 3,500. Then we've got the functional residue volume. In this case, we are talking about the sum of the expiratory reserve volume and the residue volume that can remain still in the lungs even after forceful breathing. So when you total it out together, you are going to have the functional residue volume, and it amounts to about 2,300 milliliters. And we also have the vital capacity. The vital capacity in this case equals to the inspiratory reserve volume plus the tidal volume plus the expiratory reserve volume. So this actually, it is broad because it includes the whole air that can be inspired or rather inhaled at the forceful breathing, and that which can be accommodated under the tidal volume, and that one which can be actually exhaled after the forceful expiration. In short, the whole amount of air that can be accommodated in the forceful respiration, both inhalation part and the exhalation part. When you add it together, you are going to make the the vital capacity. Friends, thank you very much. This seems to have brought us to the end of today's discussion. It's been awesome to learn on the breathing mechanism. We have seen three phases that are actually involved in the breathing mechanism, which is the inspiration, expiration, and the pause phase. And we have also seen how muscles actually plays the role in the breathing mechanism, and we have benefited to see the lung volumes together with the phases that are actually involved in the lungs. This has been beneficial indeed, and thank you very much for your time and the attention. Ensure that you understand these lessons to the fullest. Thank you.